Welcome everyone. The webinar will begin at the top of the hour and will be recorded. Connect with the Campaign for Grade Level Reading on social media. On Facebook, like the page Campaign for GLR, and on Twitter, follow the account at Reading by Third. Use the hashtags GLReading and or Learning Tuesdays and tag to tweet anything you learn from today's conversation, and we'll be sure to retweet it. We ask that you share your questions and reflections on social media. So once again, like the page Campaign for GLR on Facebook, and on Twitter, follow the account at Reading by Third. The webinar will begin shortly.
Hi, everyone. I am Becky Miles-Polka, and I'm a senior consultant with the Campaign for Grade Level Reading. And I would like to welcome you all to today's webinar as we close out what has been an incredible month of learning and celebrating the extraordinary efforts across our national network of over 350 communities. Before we get started, I'd like to go over a couple of quick housekeeping details with you all. So first, I'd like to encourage you to use the chat box function to introduce yourself, share your name and your organization. And when you do that, please be sure to check to select all panelists and attendees so that everyone knows who's in the room with us today. All attendees will be in listen-only mode during the webinar to avoid any background noises and distractions, but we strongly encourage you to actively engage with us during this webinar. So please post any questions that you may have during in the Q&A box, and we will share them with the presenters as we move to the Q&A portion of the webinar. Today's webinar is being recorded, and it's also live on Facebook. You'll receive a link to that recording in a follow-up email that will go out later this week. And then finally, we'll be posting a brief, what did you think about the conversation today, survey poll, as we close out the webinar today. And it's really helpful for us if you take a few moments to fill that out so that we have your insights and your feelings about the conversation today, and it really helps us with our commitment to continuous improvement. As you can see on the next slide, we have a great number of sessions planned for the next few weeks, and they are every week on Tuesdays at this 3 p.m. Eastern time slot. So you can see we're going to be talking about connecting digital deserts, leveraging the power of data and relationships, and then on August 18th, talking about after-school opportunities. We hope that this regular schedule makes it easier for you to connect with us on a regular basis, and that you'll take advantage of these learning opportunities. And we've now hosted over 40 of them since we started GLR Learning Tuesdays in September. And we would encourage you to visit CLIP, the campaign's Learning for Impact and Improvement platform, where we have archives of all of those webinars, and you can get access to them. I'll be posting a link for you to be able to join CLIP if you're not part of it, and also a link to where you can get access to those webinars. So with that, with all those details out of the way, let's go ahead and get started. We have a couple of goals for you today. One is to understand the importance of foundational relationships that are essential for the promotion and prevention activities for population-based efforts in child health and early childhood communities. And then secondly, to deepen your knowledge of practices that advance early relational health with equity in child health care, home visiting, and early childhood system building. We know that with the months of COVID-related stressors that we have seen on families, that it's clear these effects have the potential to be catastrophic, most especially for children from low-income families. And yet, children are born, they're growing and thriving in many ways during this pandemic. Our webinar today, titled Relationships Matter, comes at a critical time as we look toward how we can best support families during an unprecedented period in our country. Early relational health has emerged in recent years as a critical concept across systems for supporting families in the earliest years of a child's life, And today we want to explore this concept with you in more depth and envision what it could look like if community services and structures, both informal and formal, embrace both the science and the values of supporting families with young children, especially those families that have been historically marginalized. And as we know, the pandemic has exposed the extensive inequities that exist across our country. We know that we're going to be in a period of fiscal contraction for some unknown period of time. But with these unforeseen stressors come unforeseen opportunities to innovate within our local communities. And we hope that our conversation today will leave you with some optimism and perhaps a North Star as you see how you might begin to advance these ideas within your own networks. And I'm delighted today to share a little bit of information about our great panel. And there is a link to their bios. I won't go into their full bios because they're quite extensive. We're very, very lucky to have all these folks with us today. We'll begin with David Willis. Dr. Willis is a senior fellow with the Center for the Study of Social Policy and CSSP, where he leads the National Initiative to Advance Early Relational Health for Child Health and Communities. He's a boarded developmental behavioral pediatrician, and he was a clinician in Oregon for more than 30 years with a practice focused on early childhood development and family therapy. And from 2012 to 2018, he served as director of the Division of Home Visiting and Early Childhood Services at HRSA in the Maternal and Child Health Bureau, and continues to be a thought leader in home visiting and early childhood systems. Dr. Dana Long has been a primary care pediatrician for over 20 years at the University of California in San Francisco at Benioff Children's Hospital in Oakland. For the past 5 years, she has also served as the director of the Center for Child and Community Health at Benioff. She dedicates her career to eliminating childhood health inequities that lead to poor health, financial, and education outcomes for families and young children on both the individual and population levels. Mary McCrane has over 25 years of experience developing and managing improvements of state and national projects aimed at advancing maternal, infant, and family outcomes, focusing on infant mental health and relational wellness. Currently, through her work at EDC, she is the managing director of a portfolio of early childhood health and quality improvement programs, including the HRSA-funded Home Visiting Collaborative Improvement and Innovation Network. Nikki Shearman is responsible for guiding the planning process to build out Reach and Read's strategic roadmap, Next Chapter, and for taking the lead in implementing the plan around Reach Out and Read's leadership role in shaping pediatric primary care to promote nurturing family-child relationships. She also coordinates the strategy for research and evaluation that demonstrates Reach Out and Read's impact. And last but not least, Jordana Ash is the first director of strategic partnerships at the Hemera Foundation. She joined this private family foundation in July 2019 to lead work across child and adolescent mental health, development, and well-being. Her efforts focus on building partnerships to identify, explore, and help ameliorate challenges that affect children and young people, families, and communities. This new role comes after spending 5 years working to advance early childhood mental health policy and practice at the Colorado Office of Early Childhood. And now that you know a little bit about our presenters, we want to know a little bit about you. So please take a moment to share with us what your current field of work is. So we have a sense, our panelists have a sense of who we're talking to today. And as we do that, I'm going to switch over and we will start with Dr. Willis, who's going to share with us some background on early relational health. And Dr. Willis is going to pull up his slides and we'll get started shortly.
Great, I hope you can see my slides.
Yeah, so David, can you see the poll? So we have quite a
I
spread.
can, it's spectacular.
Yeah.
Great, all of the members across our various fields in early childhood. It's spectacular to be present.
Yes.
So shall I begin?
Yeah, Jerry, let's pull up that other slide. Not this one, not that this is the last poll. The one on folks' understanding of early relational health. We'll get that poll and then we'll get started with David. Hey, Jerry, I think we had one other poll. You know what? I think we're going to go ahead and David, we're just going to have you get started with,
Fabulous.
with your remarks.
Fabulous. Hope you can hear me. I'm delighted to be with you all today. And thanks, Becky, and to the campaign for inviting us and this wonderful panel of my colleagues to talk about early relational health. As is true, this is an incredibly hard time in this moment where the triple crisis, we might say, that is upon us and in so many communities across the country and for families of the epidemic of COVID, the economic free fall for so many families, and the elevation of this anti-racist moment and its importance to really focus on equity and the needs of families most challenged for us. But there's also a silver lining that we want to really bring forward to keep in our mind, and that is the optimism or the North Star comes from really focusing on the importance of relationships that can surround families at every level of communities, not the least of which are the relationships in early childhood that focus around young children. I've spent a career, as has many, focusing on the importance of the earliest years and the challenge we know that the future capacities of health, development, and early learning start incredibly early in those earliest periods. And it's important that we focus intentionally on the experiences that young families bring together with their newest members of their families, babies and toddlers, and forward. We call that space the early relational health space. The science has been clear in our field, developing over the last decade, from the decade of the brain to the movement around toxic stress, to the resiliency and moments of recognizing the critical importance of relationships. And we know that the core story of child development in building healthy brains and building future capacities and mitigating toxic stress requires a focus on the environment of relationships. And the shout out about the importance of early relational health is to be very intentional about focusing on that earliest relationship experience itself. How can we elevate this focus on the relational experiences that infants and toddlers and families create, all relationships that surround those earliest periods of development, those first 1,000 days, if not those first 500 days, the criticalness of early relational health that builds the positive and nurturing relationships that advance physical health and development, social well-being, and resiliency. This is within this concept that's also emerging about health outcomes of positive experiences. The positive experiences around all people help prevent and mitigate the vulnerabilities from toxic stress that if one is isolated and alone without buffering support of strong, connected, authentic, reasonable, safe, and positive and nurturing risk experiences, risks grow. We're trying to strengthen and capture this space about early relational health. We talk about this space being about the foundational relationships of human development. This is not a new field. This is capturing the knowledge that we know from the related fields of child psychology, child development, mental health, infant mental health, and elevating that work towards population-focused prevention, promotion efforts for all people. It all has to be focused with an equity view, and that is a partnering with families, honoring their strengths, honoring the history of culture, honoring the strengths that surround communities and the hopes that all families have for their children. People say, what does it look like? A few examples.
Uh-oh.
So very quickly, you see the joy between them. You see this, the back and forth interaction. You recognize that each is attentive to the other. As you witness this experience, I suspect you find your heart filled with joy and delight. And I suspect you recognize by knowing what you're observing that the relationship appears to have strength, it's healthy, it's supportive, and it's encouraging. In similar ways, you may have remembered witnessing this beautiful story of now an older child.
They need to work on that, right? Yes, okay. Did you understand it though? No. Okay. All right.
Oops. Enjoy this amazing dance that's going on between this nonverbal toddler and his father, and ask yourself, what am I witnessing beyond the delight and the joy of being in this very intimate moment? But ask yourself what you're seeing that you would describe that is strong, healthy, and exciting.
Not this one. This is the grand finale of this.
You see back and forth interaction.
That's what I was wondering. I don't know what they're gonna do next season because they did some stuff this time. Exactly what I was
saying. Each responsive, if not imitating the other.
Oh yeah.
They clearly are in the same moment, in the same contact, in the same joy.
Right. Don't bring that again. You know what I'm saying? Don't do the same stuff. You know what I'm saying? Yeah,
and there's shifts of some of the emotional content, a little surprise.
Yeah.
A deep respect for one another.
Like go somewhere else with that, but don't bring it here. You know what I'm saying?
Serve and return.
Yeah.
Moments of respect.
That's what I said. It was like, ah.
That's the space of relational health that you're witnessing in front of you in that very moment of being with them. That's the relational health context. We know from the history, from child development, and from multiple layers of study in multiple fields, that relational health develops over time. It's sequential, it's predictable, it's observable, and it is ultimately measurable. One can witness in all of the experiences and times we have with families and with their young children, one can see in the development of their sequences from shared attention to engagement to responsiveness to that delight and joy together that's evolutionary and developmental to a pacing of interaction, to an initiation of interaction, to an imitative ability, and ultimately towards a shared goal. You just witnessed that in those videos from a 6-month-old where the joy of being together and reacting to move developmentally up the sequence to where we saw a shared joy of that moment of nonverbal communication with each other, building upon all the skills that have been developed. There's a huge neuroscience of understanding that is increasingly growing to understand the synchrony that goes on in the development of the brain from the interactions with others. We know that in every system of physiology in the next, in a baby toddler's development is entrained to the physiology and the experience of the one they're interacting with. We can see it behaviorally. We can see it in microanalysis of video interaction. We can witness it in terms of stress regulation systems and heart rate variability that become coupled in the interaction between the two synchronously. One can see it in the endocrine systems of stress hormones and regulatory hormones. One can see it in the attachment hormones, and one can see that synchrony in brain wave activity and interactions. The next generation's health and development and skills are built by this entrainment and synchrony by the relationship experiences themselves. So we're here to talk about how focusing on a relational health frame is a shift of mindset. It recognizes the importance of focusing on foundational and ongoing relationships. It has arisen from the deep awareness of listening to families and communities and culture. It's really about honoring the positive relationships, environments, that engagement that that promote a well-being stance. We focus deeply on this effort being around a focus on human dignity, deeply opposed to systemic racism, recognizing the criticalness of an anti-racist frame. We know that an early relational health frame is science-based, strength-based, and family-centric, but it's not about a program. It's really about an all-in strategy, and it's about a mind shift that we focus intentionally on the relationships of all our families that we see. This will bring you to recognize the need for public policy changes. This brings to you an awareness that the opportunity in front of us with the necessary building back better, kinder, and gentler approaches that are going to be necessary post-COVID brings us to an opportunity to focus ever more strongly on this relational health frame. So let me turn it forward now to my dear friend, Dana Long, right? I'll stop sharing my slides.
Thank you so much, Dr. Willis. That was really inspiring, and certainly my heart feels better after watching those videos. So as Becky had introduced me, I'm a primary care pediatrician, and I work within a safety net hospital that only sees children. And the vast majority of our children, being that we're a safety net, are families of color and families that are low income. So I want to bring your attention to this picture. This picture is actually one of my amazing coworkers, Dr. Noor, and it was a picture that was recently in the San Francisco Chronicle about 2 weeks ago. And it was really highlighting the desire of us as pediatricians to make sure that we are staying in contact with our families during these triple pandemics of COVID, racism, and the economic fallout, and to make sure that not only are we supporting vaccinations and the physical health of children, but that we also are supporting their social emotional well-being. And what does that look like for a pediatrician as a healthcare worker when we are constantly sort of have our eye protection on, our face masks on, our gowns or our coats on? That ability to connect is something that we've really been working on with families so that we can support social emotional wellness. Next slide. We are acknowledging with our families that we are really in this midst of unprecedented times, and that supporting families as we as providers and our caretakers are having a multitude of feelings, responsibilities, fears, and joys, and saying that all of this is happening, and acknowledging that the response to stress is valid, and our uncertainty about what's going to happen, particularly now with school reopenings. As many of you know, in California, our governor has announced that we're going to be distance learning for the fall, and realizing what that means for our families is pretty profound. We acknowledge that there's really no better time to practice compassion and collective care right now. This is the work of mutuality that is necessary, and that we need to reflect, inquire, and prioritize what is most critical, which is really focusing on relationships. Next slide. I love this picture of one of my families because what is so palpable in this picture is the love and the commitment that is there. And this commitment transcends to us as healthcare providers, making sure that we are serving and getting through this pandemic together. Next slide. So I wanted to add a couple of case studies to the information that you just got from Dr. Willis about how important it is to support young children in clinic right now. And so the first case study is about how are we as pediatricians really doing developmental and social emotional screening in a time of distance learning, right? And so right now the protocol in many healthcare settings, including mine, is that you can't come into the building until you're symptom screened and you're wearing a mask. And all staff is wearing masks and protecting ourselves with PPE. And for a 9-month-old, right, typically the 9-month visit is a visit where we do developmental screening and more social emotional screening. It is a challenge for us as pediatricians to actually do a developmental screen when we have face shields and masks on, and the 9-month-old will see us and they'll start to cry. Right? And so recognizing how do we actually support social emotional well-being and doing this screening, which is part of the policy of our American Academy of Pediatrics. And one of the really amazing ways that we've been pivoting with families to have more comprehensive, intimate conversations is through telehealth. And so I recently had a conversation with a mom of a toddler talking about how she is supporting her toddler's social emotional development and ability to connect, particularly in this time where racism is so much in our face. And I mentioned to her that we're having a really hard time right now. Myself, as an African-American woman with 3 sons, I know how hard the world is. And her response to me about her 3-year-old is that, you know, we're doing okay. We're doing okay because he has uncles and cousins and a father, and he knows what is possible for him. He is spending time with his cousins and he sees himself in them, right? And so this mom was really focusing and capitalizing on these positive relationships that her 3-year-old has with other supportive buffering adults in the house. I am one of the principal investigators on a tool that we call PEARLS, which is the Pediatric Early Adversity and Related Life Event Screen that is now being used in the state of California and incentivized by the state for screening for every single family that has Medicaid for children on an annual basis. Recently, during an in-person visit, I did a PEARL screen on a preschooler who was going to start transitional kindergarten. And in that conversation, I asked the mother, how did this feel? How did it feel to answer these hard questions? And these questions are questions about abuse, neglect, and household challenges, as well as questions around social emotional well-being and determinants of health, such as food insecurity, housing instability, experiences of discrimination, community violence. And the response that I received was that this caregiver was so amazingly thankful that we took the time to answer the questions, because these issues are so prevalent in our society that understanding that intervening early by having safe, stable, buffering conversations and safe spaces to actually talk about hard things was not only going to help her relationship with her child, but going to improve the health outcomes for that child. And lastly, I just want to stress that social emotional well-being starts early on, right? It starts as a continuum from preconception, conception, and thereafter. And so being able to really support teenagers during this pandemic is also super important. Being able to have conversations with our teenagers about stress and trauma and buffering relationships and family planning are really important as they themselves are struggling to stay connected to one another. Next slide. In the research study that we've been working on around adverse childhood experiences, we interviewed many providers and asked them, how would you like to support families when screening for trauma? And we did a thematic analysis, and we basically came up with this acronym NOTE, which is how we actually are training providers across the state in California to respond to families who screen for positive ACEs. And NOTE stands for really noticing the strengths of the caregiver-child relationship and then commenting on them. And so, for instance, to comment, you know, I noticed that every time you smile at your baby smiles back at you. Or she loves it when you give her hugs. Or the fact that, you know, it seems as if she just really wants to sit in your lap, and that's amazing, right? Making sure that you're noticing and vocalizing your observations and to repeat them back to the family so they know about how strong and amazing they are. The other piece of this is offering the science about how early childhood relationships actually impact health outcomes, and to talk about how, for instance, trauma actually affects our neurobiologic systems and can cause dysregulation, and how the biggest buffer for trauma is the relationship. T is to offer tools. Whether that tool is handing the family a book and talking, reading, singing, or that tool is about connecting families to resources in the community. And the E is for empowering families, to let them know that we're here for them, that we got them, that they are a good parent, and that every day is another day to start over. Next slide. Especially now, I often talk to families about the fact that there's universal trauma, there's universal anxiety right now, and how do we re-regulate our systems? One tool that I often use, and I practice this with my families when I do my telehealth visits, is that I have the family sit up with their legs grounded on the floor. And then we practice breathing, right? There's a type of breathing that's called 4-1-5 breathing, where you breathe in for 4 seconds, you hold it, you breathe out for 5 seconds. And the notion of practicing paced breathing throughout the day, there is evidence that it actually helps flip the switch from your sympathetic nervous system, which is the part of your nervous system that gets activated when you're in that fight or flight response, to our parasympathetic nervous system, which is our calm nervous system. And then focusing on safety, purpose, and connecting. Right, and so the safety is about routine, establishing some type of daily structure, having shared meals, exercising, sleep. Limiting your access to the news is often really important these days, right? Connecting through healing relationships. And then the notion of purpose, which is having a future orientation to focus on what you can do, what you can control. Next slide. The Office of the Surgeon General in California has put out a stress relief playbook that I'm happy to share with the campaign. I can provide the link in the chat. And the stress relief playbook really has 6 very helpful tools to help to support relationships right now. The first is to stay connected to our communities and to each other, right? The second is exercise, sleep, and it's nutrition, not in the sense that you need to actually be on a diet, but this recognition that when your neuroendocrine system is activated, you have higher levels of cortisol that really are encouraging us to reach for those high sugar, high fat, highly processed foods. But ultimately, it comes back to bite you, right? And so really recognizing when you're wanting to lean into food for sustenance right now and saying, oh, that's because my cortisol level must be dysregulated, and just having some intentionality around that. The next is mental health and behavioral support, and then mindfulness, meditation, and spiritual connection. Next slide. So these are just some of the things that we're doing within the pediatric realm, and I'm happy to talk to you guys about these tools more. Here's my contact information, and this is my little guy. He's my last of 3, and I'm going to pass it to Mary. Thank you.
Thanks, Dana. Before we go to Mary, we have time for a little bit of conversation with you and David. I have a couple of questions. But Dana, I wondered if you would share the delightful story that you shared with us about your, recently about your son. If you wouldn't mind taking a couple of minutes, it was just so incredible.
So one of the stories that I had shared when I was on the phone with Becky and David is that, so my youngest, who you just saw the picture of, he recently told me, he woke up and he said, Mom, he just finished 2nd grade. He said, Mom, this is the life I've always dreamed of. I get to be home with you, right? And so thinking about how stressed and anxious we all are right now as adults, but as children, right, they get to actually spend time with the people in their life who they love. And for me, that was such a great example of the fact that he feels supported and cared for, and that often we actually are removing ourselves from the life of children because we get so busy. There was a video that was attached to that comment from him, and the video was, Mom, this was you before the pandemic. And I jumped out of bed and was running around crazy like a chicken with my head off. And then he said, Mom, this is you after the pandemic. And I get up slowly, I'm taking big breaths, I'm looking around, I'm giving him hugs. And so from the perspective of a child, right, early health and relationships have been so important, and it has actually created this buffer around him where he feels quite safe and secure. And I thought that was a great image.
Such a great story, thank you. So I have a couple of questions for you and David, and feel free just to chime in if you have something else that you want to share now. But one of the things I wondered, and maybe David take this first, why has early relational health gained so much traction in recent years, and how widely do you think that this concept is being embraced? Our poll showed that, you know, probably half or more had a limited amount of understanding of the concept. So share a little bit with us about that.
Yeah, I think it's part of a movement that this country is recognizing that we may have gotten too stretched into being independent as opposed to being connected. And I think that we're learning that so many of our youth feel as though they're lonely. We know that families are stretched in all directions and running so rapidly that there's this thirst and awareness that relationships really matter. The science has been there and been growing, but I think the public, and I think parents, and I think the professionals that work with families are really thinking about, we really need to start centering about strengthening the relationships as both prevention strategies as well as building future health strategies. I'm certainly witnessing that. The pediatric community really recognizes that relationships really matter. The early childhood system community, I've been struck as we talk about the importance of foundational relationships, how everybody's head goes, yes, yes. And if we look at the scientific community of child development, we all know that relationships are central to building health, wellness, and well-being. This movement is about, let's make that intentional. Ask yourself constantly, are all things we do, from policy to decision-making to our actions, relationship-centric? Are we consciously focused on making certain that there are buffering, supportive, positive, and available relationships around our youngest children? So I think that's part of a movement of discovery. But lastly, I would say at this moment in time of COVID, I've been really struck by, first of all, Dana's story, which calls out a child experience. I experienced that with my nephews just this past weekend, who were saying exactly the same thing spontaneously, that they love hanging around home, that they love being together. And one of my aunts said to my daughter-in-law, I've not seen your children have that twinkle in their eye for such a long time. That sense of connectedness really matters, even in hard times. So I think that there's a growing awareness of the importance of being really focused relationally at all levels of our work.
Dana, anything to add to that at all?
We're at this stage where we have to all move forward. And this pandemic has taught us lessons about relationships and how critical they are, and how, as David just mentioned, we lost focus on that, particularly around our young children. And I'm hoping, as we are building a better tomorrow, that we really can weave in the early relational aspect and actually help to support parents better, support their children.
Might I add, Becky, that we have a growing mental health epidemic in our nation. And although we talk about treating it, one has to ask the harder questions of what do we do to prevent it? Mm-hmm. And the prevention of mental health disturbances, of course, is addressing trauma, and addressing adversity, and addressing the social determinants. But it also is buffering by strong relationship experiences. And we've got to call that out intentionally in terms of addressing some of the scourges that we have, unfortunately, for young kids, where their social emotional weaknesses coming to school are challenging, where their early learning and reading capacities are not as well developed as they could be, by focusing early about strengthening strong relationships early, and about countering all the challenges that if children raise themselves alone, they don't learn how to regulate emotional states very well, which unfortunately lends itself to some of the future challenges that we have, that we lament and struggle with our children and young families. So this movement is also a strong human capital building agenda for future well-being at every level of human capacity.
There's one other piece that I just want to add to this conversation, and that's highlighting the anti-racist work and the screening for racism and discrimination, and how there's a growing body of literature that racism itself is stressful and experienced early on and can lead to poor health. In some of the pilot studies that we did around early childhood adversity, we screened our parents for if their young children had experienced racism. We were recruiting children between the ages of 0 to up to the 12th birthday, but the average age was 5.9 years of life. And what we found is that already these 5-year-olds, approximately 20% had already experienced discrimination at an early age. And recognizing that those young experiences of discrimination are causing dysregulation, potentially a toxic stress physiology, and leading to poor health. And we have to be mindful that how are we actually screening for racism? How are we actually talking about it? And how are we supporting children and parents to manage it and eliminate it?
And Dana, that calls out the criticalness of thinking about community building. It calls out the criticalness of thinking about addressing the poverty issues that are really about racist policy. It calls out the criticalness of surrounding every young family in every community with resiliency, supports, and strength about community building, because that's how we begin to counter the risks and the challenges that heretofore have been hidden, not the least of which is related to the importance of racism and policy structures that have disrupted human development in such ways.
Yes. Well, this conversation between the two of you could keep going on, and we'd all like to sit down with you, but we have so much more to hear about today. And David, I think your last comment is a perfect segue to Mary's remarks and how some of these systems that we all have in our communities can help support early relational health. So Mary, I'm going to turn it over to you.
All right, thank you. Yes, thank you. Thank you, everybody. I'm really excited I get to talk about one of my favorite topics related to relational health and home visiting. And if you think about what an amazing opportunity we have to build relationships, if you think about home visiting and other early childhood programs in the community, they can almost serve as a protective factor or a buffer against some of the risk and adversity that so many of our families are facing. But then a question to pause and ask in some ways is, who's taking care of the home visitors and who's taking care of the preschool teachers that are also walking around with a burden of stress? And what are some practices that we can all put in place to really support home visitors as they are going into homes and really building deep connections with the families that we really care about protecting? So I just want to start with one of my favorite quotes on the next slide. This comes from William Schaefer, an infant mental health specialist, long-term mentor in Michigan, who says, what gets set in early life is one's deepest beliefs about human relationships, and these determine how a person goes about learning, using help, and parenting one's own children. So if we think about home visiting, early care and education, the places that our babies and toddlers and young children go to grow and learn, what an amazing opportunity we have to really invest and strengthen those systems. So how can home visiting impact early relational health? If you think about home visitors going into a home and following fidelity of their home visiting model, they're often looking at helping families recognize developmental milestones, looking at health and safety. But I know when I was doing home visiting work early in my career, oftentimes those home visits turned to talking about stress, talking about relationships, talking about fears. And by being able to hold that and share that with a family, you parallel and they're able to better provide that for their children as well. It's a pretty tall order, but there's such an impact that home visiting in early childhood can make. I often think about home visitors as the glue that is connecting to the family and connecting the family to the community and all those different kinds of support systems that they need. And when you're in somebody's home, you build a very special connection of trust. And not all of us get to do that with families. So what are some opportunities that we have in home visiting? So if you think about an early childhood system within home visiting, there's so much opportunity, but what we find sometimes is that there's gaps in our system. So if we think about your community that you're living in right now, and if you knew that every home visitor had the training and reflective support they needed to really hold the stress and do a wonderful job, that they were able to understand relational health in a way where they could do surveillance and screening for every family at at a rate of periodicity that really had an impact. And then you were able to access those kinds of mental health supports early, as Dr. Willis mentioned, and then you were able to really address community coordination. You can imagine those are amazing protective factors for families. So let's talk a little bit about each one of these, and I'll give you some examples of how some states or communities have put these into place. So when we think about training and reflective support, I love this quote by Brenda Jones Harden. I'm sure many of you have heard of it, but if we think about what do we need to do for the home visitors? We need to take care of home visitors so they can take care of families, so families can take care of their children. I know, again, when I was doing this work myself, I wasn't able to just go home many days and turn it off and not think about the beautiful children and families that I was supporting. So what can we do to help home visitors really carry that along? We know that in home visiting, anywhere from 28 to 60% of mothers will experience maternal depression. Maternal depression is often comorbid with substance abuse, and in some ways, they're more likely to have intimate partner violence. How do home visitors carry that and support that? And in some of the research I've read and been a part of, often home visitors will say, I'm not equipped. I want to do this job. I'm good at this job. But sometimes there are so many things, I'm afraid I'm going to let the family down and I need help. So let's go to the next slide, and I'll just give you an example of one state's experiences. So I wove in a little bit of Part C in here because I think of Part C as, you know, oftentimes being home-based and doing home visiting work. So in Michigan, Part C is really aiming to improve social and emotional well-being of young children through their state systemic improvement plan. So what they're providing is online virtual training and coaching utilizing the pyramid model modules to train everybody in the state it's open to and no cost to really learn about social and emotional milestones, healthy relationships, and we get an opportunity to really talk and dialogue, practice, come back to the next module and tell everybody how it went. Programs are also working cross-system to leverage funding for group reflective supervision. So sometimes we say, oh, we don't have enough funding to do that reflective supervision support. But if everybody puts in a little bit for one reflective supervisor, before you know it, you've got a nice group situation with people that are really benefiting. So just some considerations at the local level. So let's move on to surveillance and screening. Others have talked about this already, but when you think about surveillance, it seems so easy just to ask, you know, how is your relationship going with your baby? Or to narrate some of those behaviors. But what I've heard to home visitors is, I need tools and tips to get comfortable before this becomes natural to me. So being able to do simple strategies to ask families, like I think about this picture on the screen and just being able to say, Mom, your eyes are wide open, your mouth is smiling, look at your baby's eyebrows, they're up high, his mouth is open. He's really enjoying this time together with you. And helping home visitors to make that surveillance and that questioning part of their daily routine at every single visit can really be impactful. And then parents start to say, well, yeah, we do that a lot and somebody's noticing, and it's really impactful. We can also create policy and cross-system around implementation of early relationship screening tools like the Piccolo, the Massey Campbell. There are wonderful tools out there, many at very low cost, that we can put into practice that are standardized, norm referenced, and reliable and valid. So a few quick examples I'll give you of ways that people are doing surveillance and screening. These are examples from the Home Visiting Collaborative Improvement and Innovation Network that I help oversee for McD Home Visiting. So I'll just, in a quick nutshell, tell you how easy surveillance, it's not easy, but little tips can help. So in home visiting, one of the things that we really wanted to grow is asking parents on every single visit about their child's development, growth, learning. And I would add here, relationship or relational health. You can see on the data slide here that folks started out really high, but when we went to operationally define what surveillance meant, a lot of the home visitors said, oh, you mean we need to do this at every visit? And we said, yeah, that's the goal. So one home visitor had this idea that spread like wildfire. All they did was put a sticker on their home visiting log that said, did you ask the parent about their child's development, growth, and learning and behavior? And the rates of this just went up and were sustained. And this was a simple tip that was stolen shamelessly across all of the home visiting programs. The other quick thing is around, in McV, there are performance measures to really grow relational health or support it around surveillance screening, maternal depression screening and referral, and parent-child interaction. One more quick tip, several teams across the country really worked hard at promoting symptom reduction of maternal depression in home visiting. And the simple kinds of strategies they put into place was a tracker. Am I screening at the correct periodicity for maternal depression? They talked about that in supervision with their administrators. There was a referral decision tree, so home visitors felt confident of when to refer and where to refer. They instituted internal prevention programs like Mothers and Babies to help parents reduce stress and really impact that relationship. And then home visitors tracked the status of referral and engaged in 30-day rescreens of depression. Next slide. The next thing I wanted to bring up quickly is infant and early childhood mental health consultation. If you haven't heard about the Center of Excellence for Infant and Early Childhood Mental Health Consultation, you can go there and find out all about it and get access to wonderful resources. But basically, a mental health specialist is paired with primary care, early education, home visitors, to really build the capacity of adults to nurture the relationships with young children to offset some of that early adversity and risk. Very impactful, something to invest in. It's often one of the, a very hard intervention to fund because it's prevention, but we know that the outcomes are incredible and there's a lot of evidence base behind it. All right, we can move on. I think you all will have access to these slides, so I won't read all of these examples to you, but there are many states that have put mental health consultation into practice, like Alameda County in California, Louisiana, Illinois. There's too many to mention, so I'm happy to share more resources and provide linkages to some of these incredible resources. So let's wrap up here with coordination of care. I love this quote by Edward Deming. Every system is perfectly designed to get the result that it does. So if your system isn't working for families, we have to step out and do something different. So we know that home visiting programs linking with primary care can lead to many improved outcomes in health, social, economic, cultural factors, and so forth. So I'm going to give you just a few examples. So if we think about coordinated care between home visiting and primary care, for healthcare, having patients consent to sharing information with their home visitors can really decrease duplication in screening and other efforts. And with the home visitor being that relationship link, it can also lead to following care plans that primary care providers engage in with families. And then lastly, on the next slide, just a quick example here that partnering with home visiting programs can really strengthen that continuum of support and services for treating things like maternal depression and so forth. Okay. So hopefully you've got a few tips about how you can strengthen these critical system drivers for early relational health in home visiting. It's definitely worth the investment with those frontline providers and the impact they can have for families. So I think a few questions have come in. So I'll take a look at the chat as we transition on to the next speaker. So thank you everybody for your time.
Thank you, Mary. That was great. And we've had lots of very positive remarks in the chat as well. So now we're going to transition to Nikki Shearman, who's with Reach Out and Read. And Reach Out and Read has really embraced this, this work around early relational health. And we had a little bit of a teaser webinar in December, and it's great to have Nikki back to share more about where Reach Out and Read is at. So Nikki, I'll turn it over to you.
Thank you, Becky, and thank you to David and to the Campaign for Grade Level Reading for having us along here. As Becky said, we've been looking at early relational health, been inadvertently promoting early relational health for many, many years, but we're focusing on it a little bit more strongly now. If we can go to the next slide. Talking about defining the trajectory of children's lives and how positive childhood experiences achieve that, what we've been talking about so far. How can Reach Out and Read be part of your community's efforts to promote early relational health? Reach Out and Read works as part of pediatric primary care. So the benefits of that is that we have population level access to children in the critical early years of life. And then there's that trusted relationship that we saw that Dana was talking to us about between clinicians and families with young children. And then Reach Out and Read sits within pediatric primary care. We have a simple model of promotion of positive, language-rich parent and caregiver-child interactions through early literacy. What happens is that in the first 5 years of life, at every well child visit, our Reach Out and Read trained pediatric care providers, their family physicians, their pediatricians, their nurse practitioners, they talk to families about the importance of engaging with their young children. They encourage families to sit with children on their laps, to snuggle up with them and read a book together as a way of engaging and to make that a part of daily routines. They model how to read aloud as a way of engaging with the child, to encourage serve and return responses, and to talk about the pictures. And finally, they give a new developmentally and culturally appropriate book for the child to take home and read together with their family. We're integrated into millions of routine well child visits across the nation. We have deep connections within pediatric primary care and implemented at thousands of medical clinics. And we have a proven scalable infrastructure of support for clinicians that ensures fidelity of practice and connections with the community. You go to the next slide, please. So the benefits of the Reach Out and Read model I've just mentioned were population level because we work through pediatric care. We are able to promote foundational relationships through shared reading. We're feasible, our growth is organic. Clinicians report that it's the best part of the well child visit for them. We're evidence-based. Our evidence shows that parents are 2.5 times more likely to read with their children and enjoy reading with their children after exposure to Reach Out and Read. And children's language development is improved by 3 to 6 months. And then we're scalable. We're cost efficient. It costs about $100 for 5 years to support a child through Reach Out and Read, and supported by an affiliate infrastructure. We go to the next slide, please. We're all over the map. You can see that we're in so many places throughout the United States, and so I would encourage our Campaign for Grade Level Reading communities to reach out to us, find us, and work with us to promote early relational health. You can visit our website, reachoutandread.org/find-a-site, to see if Reach Out and Read is implemented in your community. Next slide, please. We haven't got it all right. We've still got so much to learn. We know that there are challenges to achieving our goals, and we recognize that helping families begin and sustain these essential patterns of positive and responsive interactions is complex and challenging. You need money to do it, you need time to do it within the context of a well child visit, you need the skills to do it and connecting the community. So the next slide. And so as part of our 30th anniversary last year, we looked at what the next 30 years was going to look like, and we decided to embark on the next chapter, shaping the future of pediatric healthcare. And we have a vision that Reach Out and Read will maximize the potential of pediatric primary care to support the positive interactions that foster healthy brain development during the critical early years of a child's life. Next slide, please. Our strategy. Last year, we invited as many of experts in early relational health to a 30th anniversary celebration in November that we called the Forum. And we asked them to help us define our strategy. How can Reach Out and Read work with everyone out there to best promote early relational health? And we came up with a number of strategies: implementation, click again please, skill building, next click. We want to spread the word. We want to promote policy design and advocacy around early relational health. And we want to carry out research that provides the evidence for why this is important. There's a lot of evidence already, but we want to add to that. We need to be flexible. We've talked about the effect of COVID-19 on pediatric healthcare, and we've listened to and worked with our network of pediatric care providers to offer support such as short training and materials about how to deliver well childcare through telehealth visits. And we're supporting the American Academy of Pediatrics initiative, #CallYourPediatrician. Nevertheless, we believe that the promotion of secure, nurturing relationships between parents, caregivers, and their young children is essential now more than ever. And so we're also proceeding with our next chapter work. And I'm just going to pick out 3 of the areas that we started work on. So the next slide, and one more click, please. Thank you. Skill building first. COVID-19 and the response to it has shown us that healthcare transformation is driven at a grassroots level by clinicians. Reach Out and Read connects a network of 34,000 clinicians and has deep connections within the pediatric community. And we have experience, capacity, and technology for wide-scale skill building. And so one of our aims is to mobilize our network of providers to demand change that incorporates the promotion of foundational relationships into pediatric primary care. And we want to equip clinicians with skills to effectively promote foundational relationships. Next slide, please. That's not going to be easy. The sorts of skills we're looking at aren't classically part of medical education. We've got to build effective skill building in promotion of foundational relationships, and we have to consider co-design with parents and co-design with pediatric care providers. We have to think about a strengths-based approach and the use of video and self-reflection. We have to think about how to build skills in observation and guidance, and how to feasibly incorporate this into well child visits, and think about learning collaboratives. There's a lot there, but I'm very excited to be working on this project with David Willis. We have a project that we're embarking on, thinking outside the box with the training to really help bring this into pediatric care. The next slide, please. In implementation, windows and mirrors. Just cutting to my next bit, sorry. We want the families that we serve to enjoy reading the books that we send home with the child. We know that if we want to have impact, the children and families need to enjoy reading those books together. And there's a lot of research out there and also recent focus groups that we've held that have shown us that this is influenced by where the families see themselves in the books. We have a reach out and read book policy and have done for a long time that states, you can see on the slide, it is a priority that program books reflect the widest possible representation of the children and families we serve, with stories that are relevant and engaging, accurately reflect and affirm a diverse range of identities, cultures and histories, and contain illustrations that are colourful and recognisable to young children. The challenge has been that there is not a wide range of diverse and culturally responsive books at all, and certainly not at the price point that either Reach Out and Read or many of our families can afford. So the recent events around racism and anti-racism have stimulated us to initiate our Mirrors and Windows project. With our strong connections with book authors, publishers and distributors, and our buying power, we provide over 7 million books annually to families. Reach Out and Read is an opportunity to make books that are mirrors, those that represent the reader's race and culture, affirming a child's sense of identity and belonging, and windows, those that offer views of the world that the reader does not directly experience, more widely available for the families and in the communities we serve. Next slide, please. The last piece of strategy that we started work on is how we spread the word about early relational health. We're launching a Reach Out and Read podcast. Our first episode is this Thursday. We hope you'll join us. On this special episode of Reach Out and Read, we're joined by Dr. Monique Jindal, an internal medicine and pediatrics physician at Johns Hopkins, and Meg Medina, author of the Newbery Medal winning book Merci, Soirée, Change Gear, that's in French. They'll be discussing the importance of diversity in children's literature and lives. And there's also a special bonus episode with Ashley Lukashevsky, illustrator of Anti-Racist Baby, who will share her creative process and craft with us in writing and illustrating children's books with diversity in mind. So we hope you'll join us for that. You can subscribe by visiting reachoutandread.org/podcast, or find us on Apple, Stitcher, Google Play, and Spotify. And in fact, we've got David Willis coming up in an episode talking about early relational health. So you can have a double dose there. Thank you.
Thank you, Nikki, so much for that. I am always anxious. I have a 19-month-old granddaughter, and when she gets her well child checks, my son sends me a snap of the well child check, and I'm always happy to see the Reach Out and Read at the bottom of the well child check. So such a critical part of pediatric well child care. So now we're going to shift to Jordana Ash, who has some extraordinary experience working to build this out through a statewide system, and also in her new role at the Hemera Foundation, a private philanthropy. So Jordana, I'm going to turn it over to you and we'll hear what you have to share. Jordana, let's make sure you're not muted.
I am here. Thank you, everybody. I am delighted to be here and was so humbled to be asked to be part of this panel. As you can as you've been hearing, there is an amazing wealth of information from each of the panelists, and I feel like we could have gone for one of those conferences, one of those virtual conferences that you know, went on for 6 hours today. But in the interest of time, I'm going to share with you just a few thoughts, remarks, and reflections on systems building in the context of early relational health, and bring in to bear, Jerry, could you go back for a sec? And bring into bear some of the perspectives from my new role with a family foundation. And as I was asked to join this panel, I thought deeply about how I could contribute to this conversation because I joined this family foundation about a year ago, having spent, as Becky said, the previous 5 years where my entire role really was to help the state of Colorado advance early childhood mental health in a role of director in our Office of State Office for Early Childhood. And it was a brand new role, and my responsibilities ranged from kind of serving as an internal expert on issues of early childhood mental health, but really looking to institutionalize policies and practices that supported what we call early childhood mental health. But as you heard from David and Dana and the other presenters, really relational health and early relational health is grounded in those principles of what we have called infant and early childhood mental health. So in my new role now, the Hemera Foundation has long funded in contemplative practice and in the early childhood field. And I was brought on to advance the strategy around adolescent mental health and well-being. And so I was really grateful to hear both Dana and David mention the mental health pandemic that, if it's not already here, is coming as a result of this pandemic, and the spikes in mental health concerns for adolescents is certainly growing. And we at Hemera are very interested in focusing on the well-being of young people, connectedness, and their ability to navigate their world as they move into adulthood. For those of you who have any interaction with young people, and I imagine that some people on this webinar do, we are just in awe and amazed at the creativity, how smart they're being, how motivated and invested in really changing those systems that have long held them back from the opportunities and abilities to thrive. So focusing on adolescents, focusing on young children, focusing on the entire life course is critically important as we look to move from this period of this pandemic into the next phase. It's certainly not the new normal. So in thinking about systems, I'm thinking about them in new and different ways now, but I bring a long history in thinking about how to engage in systems work that has helped support it, or help support development, health and well-being for very young children and those who care for them. Because like Winnicott reminds us, there's no such thing as a baby. And what we mean by that is that there's only a baby and someone else. So a baby, a young child, and a parent, or a home visitor, or a pediatrician, a health provider, a doctor, child care provider. And so collectively, that's the system of support around very young children, and it's worthy of our intention. So Jerry, next slide, please. So I wanted to just focus for a minute on the range of community-based, local, regional agencies, organizations, policies, and practices that make up what we think about as a system. And this graphic here is just to remind us and help us think about the range of sectors that are involved in the system that affect young children and their families. So hopefully we have scientific foundations, scientific underpinnings to the system of supports that we're looking to bring to bear. We have health practices, we have educational systems, we have the interventions like the ones that Mary and Nikki shared with us. We have faith communities and support systems. We have music, art, and culture. And I think now more than ever, it's really important to think about where families draw their strength. And for many of our families, it's longstanding cultural norms, cultural supports, cultural ways of being. How these systems interact, how these sectors interact, and the interplay between them is worth thinking about if we ultimately want to benefit young children and those who love them. And we want them to have the opportunities, the experiences, and the relationships that help them thrive. And I think that's what's at the heart of relational health, really capitalizing on opportunities like the Reach Out and Read, having experiences of serve and return between a parent and a very young child, and having relationships not only with immediate parents and caregivers, but with extended family and with others who are wrapped around that young child to do its best to bring that hope, as was described early on in this panel, to young children and families. So one way to think about systems work is actually based in some of the characteristics that we heard about today. In infant mental health, we would call this a parallel process. It's the way in which systems themselves operate to their fullest effectiveness. And if you can promote these characteristics within your systems work, you have a much greater likelihood of having effective, creative, and successful systems. So I'm just going to touch on a few for the purposes of our conversation today. So first, systems themselves, cross-agency work, cross-sector work, interdisciplinary work and collaborations rely on trust and respect. Those are foundational, necessary ways of being with each other, without which there is not going to be any new progress made in our systems work. Consistency, we're in it for the long haul. Can we continue our partnership even in the absence perhaps of new funding? The consistent work over time builds those relationships that Dr. Long spoke about, and that in and of itself sets the stage for future work and for progress being made on bettering our systems for the benefit of the families we work with. Reciprocity, it's a really important concept in infant mental health and in relational health, and it's also important in the systems work. What's being brought to the table? It's not always funding. It's oftentimes some of the other kinds of help that we offer each other. What do you bring to the table? What do I bring to the table? What can we do to share our work together? And creating shared meaning, of course. That is, what's the space in between us? Can we talk enough together to be able to create a goal that might not otherwise have emerged as we are separate in our own silos and sectors? So I want to just sort of move into the concept or the idea of how does philanthropy come into play here? What's the role of philanthropy? And there's certain things to think about, both for the funders in the room and also for those of you who may seek funding to advance your programs. Oftentimes funders can take risks on new ideas. That's one of our roles. That's one of the key things that we can do so that programs can make those adaptations to reach different families, to be more effective with families. We can fund scientific inquiry that our partners tell us is missing in the field. We can finance the kind of support and connection that I'm talking about right here, the convenings, the gatherings. And we can help bring together researchers with providers and families to really have that family voice in all of our work, from the development of tools to the development of interventions to scaling propositions. We need families to help inform us. Jerry, next slide. Thank you. So here's just some areas for consideration. I was asked to dig in and to come up with some things that were really going to help the audience here today go back to their own places of work and have some actionable steps. So in the interest of time, because I know we want to get to some of the questions, I'm just going to briefly touch on these. And I've organized them from broadest to local. So by no means is this exhaustive. I'm sure all of you, if we were in conversation, would come up with other ideas. But just think about these kind of categories. What are some roles with authority and responsibility can you think of that can help move and advance an agenda around relational health? Creating positions of leadership, local communities, partnering with your Academy of Pediatrics. So I am going on now. I'm getting the prompts that you guys will have our slides. I am available for further discussion about any of these, but in the interest of time, I'm going to show you very quickly an example on the next slide of the what we did in Colorado. And the message I will leave you here with, again, busy slide, but lots in here, packed in for relational health. What I would say about this is we have a responsibility at this point in time, at this moment in time, to do like an equity audit on all of our policies, programs, interventions, and goals in order to really make sure that anything that we're putting forward is designed to build a new system with equity in mind and to undo historic infrastructure and policies that actually built in discrimination and inequity and injustice. So those of you who are interested in building out a system, I would encourage you at each step to take the time and check yourselves and ask for input and ensure that anything that comes from today on really is designed to give equal opportunity to all of our children and young families, or families with young children. Next slide. This was just an illustration of the ways in which systems come from that core of the importance of the attachment between children and their families and their caregivers, all up and down the system. It doesn't just stop with the immediate providers. It really is important to take into consideration what are the systems that surround young children all the way up to policy, research data, and public awareness. And then finally, I'm just going to leave you with a few thoughts. These are particularly designed for the funders in the room, but also for those providers, perhaps families, who are interested in moving work forward. And I would say to funders, trust your partners. They understand what's needed. They're often nervous to tell us as their funder, grant maker, if they have trouble meeting their deadlines or achieving the outcomes they had set forth. And so we need to understand that and build in opportunities to build relationships between grantees and those who are distributing funds. The best thing we can do right now is to have flexible dollars easily deployed. I've heard of great examples of streamlining applications and getting dollars out right now to those who are using them. Small grants are making a huge difference for programs and partners. Accessing your network. It's not only about the funds, which are very important, but look across your network to see who you can connect with, those on the ground doing the work, and that may help them tap into other funds or other thought partners to help them. And then finally, while there's a sense of urgency right now and there's great need, and funds are really important right now, what you're really doing is, or one thing you may do, is to take the time to plant the seeds for the future. Can you fund a relational health coordinator in a pediatric practice? Can you look to a community to see who is starting out now and will need funds for the long term? All of this matters right now because it's going to take all of us working together to make a difference for very young children and families. Thank you very much.
Thank you so much, Jordana, for your remarks. We, as you all probably have noticed, we are running long because we have so much great information to share. I think we have tried to answer any questions that have come into the Q&A box to you directly, or put the responses in the chat box, so please look there. I have a question that I'm going to ask each of our panelists to respond to. We have talked a lot about early relational health in terms of how we support families and with young children. We also know that our colleagues who are on the front lines in this work are incredibly stressed right now. Our clinical staff, our pediatricians, nurses, our home visitors, family support workers, early care and ed. So as GLR coalitions across our network, if you have any advice for how we support those folks who are on the front lines, I would love to hear it from each of you before we close out. So I'm going to start with David. I see your picture right in the middle.
I think that's joining arm in arm, recognizing that caring for the carers is every bit as important as caring for those that need supports. And so I've actually witnessed that in some pediatric practices are intentionally trying to take care of each other with some reflective time, of discussion time. I'm seeing it with networks of practices that are talking with one another and supporting one another in terms of, you know, arm in arm support and finding the hopes and the possibilities. So I think that, again, back to relational health principles, being connected to others becomes, I think, a critically important strategy, and any supports that can do so.
I want to add on to what Dr. Willis just said. So thank you for acknowledging the immense amount of stress that we're under as frontline providers, as we are balancing the priorities of our own families and then caring for our patients. One of the new trainings that we've started to initiate are staff fortitude trainings. We call these trainings We Are Resilient. We've been working with an open source educational group called Dovetail Learning, and it's focused on skill building for providers to help us get through these times based upon these core principles of centering, connecting, and collaborating. And it is about building the skills for providers to center ourselves before we go into exam rooms and to manage the stress that we're under, teaching us how to connect with our colleagues and collaborate with families. And it is necessary. It's necessary not just to have theoretical conversations that we want to be grounded, but to actually build the toolboxes for us as providers to be able to do that. And the second piece is having tangible ways to support our families through this pandemic, whether it is through care coordination, whether it is through helping us with the screening and the response for ACEs and trauma and social emotional well-being. We are looking for tangible skills to help us all get through.
Thank you, Dana. Mary, how about you?
Yeah, I'll just quickly say I so agree with what David said about connecting. I think providing time for reflection and stress reduction. And if you have access to mental health consultants, we've been doing things like office hours where providers can just come and talk about, yes, issues and stress, but also the bright spots. So we're also creating an energy of hope that we're going to get through this, and we're going to get through this together.
Thank you. Jordana?
Yes, and what I would say to all of those great ideas is a small amount of funding goes a long way. For the funders here, don't underestimate helping, for example, offset the cost of what Dana just described, or reflective supervision for frontline providers. There are ways in which these ideas bubble up, and as philanthropists, we can help get some funds out the door. In truth, it really doesn't take that much at this moment in time to support what providers need.
Thank you. A little bit goes a long way. Nikki, any
yes,
final?
Yeah, I would just add one thing, I guess, from Reach Out and Read is in our connections with our frontline providers, we've been listening and being guided by them. Tell us how we can help you. And if they need some space to talk, we have provided space to talk. If they needed extra supports and tools that we can offer, we've tried to provide those as well. So that relationship, that healthy relationship that we've been talking about between us and our providers.
Well, thank you. And as you have seen, we have our poll in progress, so please take a moment to fill that out. And I would just like to say, I got the lucky by being able to join with this group of esteemed colleagues to moderate today's conversation. It was a wealth of information, and I want to thank each of you for taking the time and contributing to this really important work today. And thanks to all of you who joined us today. As you know, we'll be getting the slides and the links shortly. And do please register for our upcoming conversations as well. And I see that my clock says we are at the bottom of the hour. So many thanks to everyone.
Thank you.
Bye.